Use of bromocriptine for the treatment of peripartum cardiomyopathy has been there for some time. Prolactin can be cleaved into a toxic 16 kilodalton prolactin fragment, also called vasoinhibin, mediated by oxidative stress. This prolactin fragment has a role in driving peripartum cardiomyopathy. Hence the role of bromocriptine in the treatment of peripartum cardiomyopathy. Suppression of lactation is a concern while using bromocriptine for peripartum cardiomyopathy. In a pilot study, 10 patients each with peripartum cardiomyopathy were randomized to open-label bromocriptine with standard heart failure care or standard heart failure care alone. One patient died in the bromocriptine group while 4 died in the control group. Significantly fewer patients in the bromocriptine group experienced the composite endpoint of poor outcome defined as death, NYHA functional class 3 or 4, or left ventricular ejection fraction less than 35% at 6 months compared to controls. Cardiac magnetic resonance imaging did not show any intracardiac thrombi. As the infants of bromocriptine treated mothers could not be breastfed, they were also studied. Infants in both groups showed normal growth and survival. German peripartum cardiomyopathy registry has also demonstrated the beneficial outcome with bromocriptine. The study showed a high recovery rate of 96% in patients on a combination of beta blocker, angiotensin converting enzyme inhibitor or angiotensin receptor blocker, and bromocriptine. Positive family history was present in 16.5% of cases. They suggested the role of several biomarkers in peripartum cardiomyopathy, including cathepsin D, the enzyme that generates 16 kilodalton prolactin fragments. A multi-center randomized study evaluated the role of bromocriptine in 63 peripartum cardiomyopathy patients with left ventricular ejection fraction of 35% or less. They were randomly assigned to either short-term treatment for 1 week or long-term treatment for 8 weeks, in addition to standard heart failure therapy. Anticoagulant therapy at a prophylactic dose was administered during bromocriptine treatment in both groups to prevent thrombotic side effects of bromocriptine. A placebo group was considered unethical given the previous registry data and pilot studies showing usefulness of bromocriptine. The treatment was well tolerated and left ventricular ejection fraction increased from a mean of 28% to 49% at 6 months as assessed by cardiac magnetic resonance imaging in the 1-week group. It increased from a mean of 27% to 51% in the 8 weeks group. No patient in the study needed heart transplantation, left ventricular assist device, or died. They concluded that there is no significant difference between the 1-week and 8-week treatment groups, though there was a trend for better full recovery in the 8-week group. There were 2 events of venous embolism and 1 peripheral artery occlusion. These occurred in the 1-week group after termination of bromocriptine therapy. Thank you for watching this video. Please subscribe, like, share, and post your valuable comment below this video.